Hello. This presentation was created by Dr. Donald Jurovich, a professor of geriatrics at the University of North Dakota. Today, we'd like to talk about dizziness. Our objectives are to describe why dizziness occurs in older adults, the evaluation of older adults with dizziness, syncope, and its treatment. The topics covered will include classification, causes of dizziness, the evaluation and management of dizziness in older adults. The importance and complexity of dizziness is that it's a common condition in older adults. Various prevalence and epidemiologic studies suggests that the occurrence of dizziness is from 4 to 30%. It increases with age. Women tend to be affected more than men. Oftentimes, it's multifactorial. Recent studies reveal that even after canalith repositioning for BPPV, approximately 23 to 70% of patients experience residual dizziness, a prolonged sense of imbalance or lightheadedness that may last for weeks or months. Let's think about dizziness in terms of an acute episode versus chronic. The acute dizziness is independent of age. Generally, it results as a disorder from one system, as opposed to the chronic condition, which is multifactorial. Some of the more common causes of acute dizziness include acute vestibular neuritis, cerebral vascular ischemia, and various cardiovascular disorders that often result in hypotension. By contrast, chronic dizziness is something that usually occurs for greater than 1 to 2 months. It is more age-specific, being more common in older adults. It has multifactorial etiologies, and it's really more or less considered a geriatric syndrome. It takes a multifactorial approach, and to focus also on medication side effects as an underlying etiology, but chronic dizziness really has some considerable consequences. It's associated with increased fear of falling. It can be associated with depressive symptoms, fall risk, and just general decline in functional ability. Vertigo is never continuous. It's there even with structural lesions, adaptation, and habituation, which can occur in weeks. If you have somebody that considers their dizziness or vertigo is persistent, ongoing, or unrelenting, generally it has a psychogenic underpinning. That's an important distinction. There are adaptive processes and habituation you can use as part of your treatment intervention, where you try to reproduce the positions that induce vertigo under obviously more controlled conditions. You don't want to be flying an airplane when you're doing habituation therapy for benign positional vertigo or other types of dizziness. If you can find a certain position that causes the dizziness, that recurrent positioning, it will help reduce the symptoms of vertigo and dizziness. If we try to classify dizziness according to symptoms, we have true vertigo. This is considered to be episodic spinning or a rotational motion, where either the person or the environment rotates. By contrast, there's presyncope episodes, where you have this sensation of you're going to faint or you feel lightheaded. Those are often the words that people describe. There's a disequilibrium syndrome where you feel off balance, either when you stand or walking. Sometimes presyncope and disequilibrium can cross over. If somebody gets up out of bed and feels lightheaded to the point of almost falling, then we have to sort it out. Orthostatic blood pressure check is one of those mechanisms for evaluating the differences between presyncope and disequilibrium. There's somewhat of a catch-all term of all other forms of dizziness. These include the more vague feelings, such as floating. Lightheadedness may be used to describe that wooziness. A mixed dizziness syndrome would be a combination of 2 more of the above, and that is the most common type. That's why it's such a challenge to deal with dizziness. Vestibular-specific disorders, including benign paroxysmal positional vertigo, Meniere's disease, idiopathic recurrent vestibulopathy acoustic neuroma, and cerebral vascular disease. The absence of spinning sensation does not automatically exclude vestibular disorders, because patients with actual vestibular disorders might describe their problem as more of an imbalance, a disequilibrium, or other sensation. That's why we have to go through a structured physical exam. Figure out what the underlying pathophysiology is of the dizziness sensation. Benign positional vertigo most often presents as an episode. It'll occur with a change in head positions. If somebody's in bed rolling over, gaze up at the sky, or look down, those can all be precipitating moments. They can be sudden, long bouts of vertigo, and most likely they result from a dislodging of otoliths in the semicircular canal. You can see on the diagram to the right a stained cross-section of the semicircular canal with little dark stones. Circled in red are otoliths. Here we have Meniere's disease. He was another French physician of fame for Dupuytren's contractures from the 1800s. Meniere never really reached full professorship, as was his career goal. He was banished to a deaf-mute institute, where he wound up describing a disease that's named after him. Meniere's disease has repeated episodes of tinnitus or ringing in the ears. There might be fluctuating in hearing loss, with a sensation of fullness in the ear. It can be associated with pretty severe vertigo. Turning towards non-vestibular issues is presyncope. This is a sensation of faintness or lightheadedness. It often is associated with decreased cerebral perfusion and is precipitated by postural changes, such as getting dizzy when standing up from a supine position. It may occur with or without measurable orthostatic hypotension. Also common in frail diminutive older adults is postprandial hypotension. You can see in the diagram that there was a large caloric challenge provided to our patients. You can see the immediate drop in the blue of the systolic blood pressure. Not so much with the diastolic, but primarily in the systolic blood pressure. You can see that it occurs within 30 minutes. There tends to be a little waffling after the first hour, but then there's a persistence after 2 hours. If you ever request orthostatic blood pressure checks on older adults postprandial, rule in or rule out this condition. It's important to do it within 30 minutes of eating or 1 to 2 hours after eating. Disequilibrium is another condition of dizziness that we need to talk about. It's a sensation of imbalance or unsteadiness. There's many factors that contribute to imbalance. Sometimes vision problems, proprioceptive disorders, particularly in paresthesias with diabetics, in musculoskeletal disorders, as well as various gait disorders, with normal pressure hydrocephalus, where you have that wobbly drunken sailor-like gait. With bifocal lenses or progressive lenses, one of the more evidence-based findings has been for older adults at falling. They should wear distance glasses alone while walking. Blurriness occurs with bifocal lenses or progressive lenses, that when they look down during the fall, they can't really compensate very well. The patient may describe a variety of symptomatology. A lot of times, there's a psychiatric cause that can be associated with depression and anxiety. POTS, postural orthostatic tachycardia syndrome, is increasingly recognized even among older adults. It is defined by a greater than or equal to 30 bpm heart rate rise on standing, without orthostatic hypotension. In vestibular migraine, newer pharmacologic options like CGRP inhibitors are under investigation and hold potential for reducing both headache and dizziness symptoms. Some of the characteristics of dizziness in older adults is, when it occurs, it usually will resolve within days to several months. It can be chronic or recurrent. Again, it has multifactorial etiology. A lot of times, it'll be associated with postural hypotension. In one study, presyncope and syncope was found to be associated 25% of the time with postural hypotension. Many times, the older adult will have anxiety or depression that accompanies the dizziness, and the use of 5 or more medications, which by definition is polypharmacy. It's also associated with dizziness, and it may not be surprising that a lot of these folks will have impaired gait and balance. The history of the evaluation of dizziness is critical. It's important to have the patient describe their condition in their own words without much prompting. Then you want to ask them more about timing. What provokes it? What will exacerbate it? Finally, find out how these symptoms are affecting the individual's function and quality of life. Does it really take them out of action, or is it a mild nuisance? Establish the range of functional disability that this is causing. When evaluating timing, look at the history to find out whether it's prolonged severe vertigo versus recurrent spontaneous attacks or chronic persistent. If you can get a sense of the timing between these three possibilities, the prolong of severe vertigo would be more suggestive of vestibular neuritis or stroke. Things such as migraine headaches that are associated with vertigo present solely as vertigo as opposed to head pain. The recurrent spontaneous attacks would be more Meniere's disease or also migraine. The persistent or chronic dizziness would be more associated with psychogenic problems and possibly cerebellar disorders or cerebellar atrophy tumor and so forth. The other part of the evaluation is to find out what provokes the dizziness. Spontaneous occurs without any known causes. If someone rolls over on the bed and gets dizzy every time, that's positional. Individuals that get up out of bed and have to sit for a while before standing up because they feel lightheaded would be experiencing a postural associated condition. Here we have the third element that we want to ask about: aggravating factors, such as head movement that causes the vertigo to be worse, then it's more likely to be a vestibular-oriented condition. The HINTS exam, evaluating head impulse, nystagmus, and skew, and the video head impulse test, VHIT, have become critical tools in differentiating central versus peripheral vestibulopathy in acute dizziness. Our first polling question for this topic is: which diagnostic tool has become increasingly important in differentiating central versus peripheral causes of acute dizziness? A. Dix-Hallpike maneuver. B. HINTS exam. C. Romberg test. Or D. Orthostatic blood pressure measurement. The correct answer is B. HINTS exam. Telemedicine techniques, including smartphone-assisted diagnostics and remote vestibular rehabilitation, sometimes gamified, have demonstrated feasibility, high patient satisfaction, and comparable results to in-person care. Virtual reality has emerged as a powerful aid in vestibular rehabilitation therapy. Recent trials show VR-based rehab yields equal or superior improvements in balance, confidence, and dizziness symptoms. Long COVID cases often include persistent dizziness and autonomic dysfunction, such as orthostatic intolerance or POTS-like conditions. Emerging research highlights clusters involving fatigue, brain fog, and dizziness. A novel frontier in vestibular medicine is the vestibular implant, an electrical stimulation device targeting the saccule in patients with bilateral vestibulopathy. Early studies suggest potential benefits for balance and gait.